Welcome to PharmacyToDose, the Critical Care Podcast. And I'm your host, Nick Peters. And wherever you are and however you are listening, thank you. Now, this is the literature review series where I collaborate with up-and-coming pharmacists, pharmacy residents, and pharmacy students. We all know how hard it is to keep up with the literature, so let us help. Now, the focus of our episode today is going to be articles published in September and October of 2021. And I have two excellent guest hosts who are going to be working with me to highlight some of the most notable kind of research studies and publications that were published for everyone during those 2 months. Now, one quick thing before we start. If you've been listening to this series, if you're interested in being a guest host for the upcoming 2022 literature review series, now is your time to pay attention. So for any current pharmacy student or resident or anyone doing postgraduate training, maybe a research fellow, apply to be a guest host for a 2022 literature review series episode. So this is a fun application, no CVs, no letters of intent. It's just a brief Google form to fill out. So that's one step of it. And the other step is to email a 60 to 90 second clip. So it can be video or audio that's describing why you want to be on the podcast and why I should pick you. Remember, be creative. That's the fun thing. That's what I'm looking for. This podcast is about having fun and thinking outside the box. So try to do that in this clip. There was a submission last year that was one of my absolute favorites. I'm going to showcase that on Twitter. So at PharmacyToDose, TO2Dose when this episode releases. So go there and see kind of some of the creativity that I'm talking about. The application will be open for the next couple weeks. So be sure to apply today. And then, you know, one thing that's going to change is right now we're reviewing 2 months of articles at one time. And sometimes it can feel like it's really hard to hit on all of the important ones, that there's been a lot of stuff coming out. So what we're going to do is try to have an episode each month instead of bi-monthly. So instead of 6 episodes, we're going to have 12. So that way we can hopefully keep these episodes a little bit shorter and, more importantly, highlight more people, more pharmacists, and more articles that can kind of help build up our libraries here. Now, today, my two guest hosts are both early in their career pharmacists who have been a joy to work with. And I'm joined by Sara Groome and Alyssa Sykuta, and we're reviewing articles published in September and October of 2021. Now, Dr. Sara Groome is the Infectious Diseases and Antimicrobial Stewardship Clinical Pharmacist at Thomas Jefferson University Hospital in Philadelphia, Pennsylvania. She obtained her bachelor's in animal sciences at Penn State University. Look at that. And her PharmD at Temple University School of Pharmacy. She completed both her PGY1 and PGY2 in infectious diseases residencies at the Thomas Jefferson University Hospital. And Sara's clinical interests include both infectious diseases and critical care. Now, Dr. Alyssa Sykuta received her PharmD from Drake University College of Pharmacy. She then completed her PGY1 pharmacy residency at the University of Iowa and her PGY2 in critical care at the Thomas Jefferson University Hospital in Philadelphia, PA. And in maybe the most exciting news of the episode, Alyssa is going to be joining the pharmacy team at Riverside Methodist Hospital in Columbus, Ohio, as an ICU and emergency medicine clinical pharmacist. So that's amazing news here. If you're looking to get in touch with either of these two pharmacists, Sara's Twitter handle is at SG_PharmD19. And then Alyssa's Twitter handle is at ASYKED PharmD. A psyched PharmD. Ooh, I like that little play on words here. So, Alyssa and Sara, welcome. I appreciate you both for taking the time to join me today. How are you both doing?
We're good. Thanks so much for having us.
Yeah, I'm excited to be on the pod. Thanks again for having us.
Now, for those who might not have caught on in the introduction, you all were co-residents. You both did your PGY2 residencies at Thomas Jefferson University Hospital. So maybe give us an explanation or try to break down how good of friends or how close you both are for the listeners here.
Yeah, so our group of PGY2s was very lucky last year in that we were all pretty close. So Sara being IB and me being critical care. And then we had a couple of other girls who were doing other PGY2s at our hospital. And we all tried to go out for dinner or happy hour weekly. I've been in Baltimore since we finished our residencies, but since I'm moving here in the next week, I actually was able to drive up to Philly earlier this week, and we were able to get happy hour, me, Sara, and one of our other co-residents, just as a kind of goodbye party. And It's really great to have such long-lasting friendships from residency.
Yeah, and I'll say that when my other co-residents came on as PGY2s, I took the initiative, one as the Philadelphia local and the PGY2 that was there as a PGY1, to be like the mother hen and show everyone around and show them where to go out to get food and dinner and coffee. So I think that's how we quickly bonded and became such great friends throughout residency.
That's an amazing. It's almost like you were like the Philadelphia ambassador to the city there. I heard a little bit of swag too as you said that you are a Philly. You're a proud Philly native, as almost everyone is that I know.
Yes, sometimes I need to tone down my little dialect a little bit, but I'm very, very Philadelphia proud.
Hey, not on this pod. You don't need to. Absolutely not. This is a pro Philadelphia podcast here, as we've had plenty of guests from there. Now, let's go ahead and get started. We got tons of fun things today. Now, most of us know that the Surviving Sepsis campaign released their 2021 updates to the guidelines, and instead of doing our normal 6-pack of studies where we kind of hit on 6 studies that have been published within these 2 months and kind of go a little bit in deeper, we actually, and by we, this is Sara and Alyssa's idea, so I need to give them the credit that they both deserve, but they had the awesome idea of highlighting a few recommendations from the guidelines and then going in depth and kind of talking about focusing on an article or a small series of articles that the guidelines use to help use as evidence for their recommendations. So I think that's absolutely great. And where we'll kind of get started is with Alyssa here talking about probably like a sepsis number that's kind of been drilled into a lot of our heads here.
Yeah, so one of the revised recommendations in the 2021 sepsis guidelines was related to fluid resuscitation. And as Nick kind of alluded to, for those of us who have spent any amount of time in critical care or the ED in the past 5-10 years, it's likely we've all had the recommended sepsis fluid resuscitation volume of 30 mils per kilo drilled into our brains. Now, there's been some debate about what type of fluid is most ideal for that resuscitation, and we'll actually get into that more here in a bit. But one of the revised recommendations in the new guidelines first challenges us to consider how much fluid we're giving and whether that 30 mils per kilo benchmark is really necessary. To understand where this revision is coming from, we have to know a bit about the history with the fluids in the sepsis guidelines first. Aggressive fluid resuscitation in sepsis has been advocated since the Surviving Sepsis campaign inception in 2004. But the 2015 sepsis bundle and subsequently the 2016 edition of the guidelines is when we actually saw that formal recommendation for the 30 mils per kilo fixed volume. At the time, this very specific volume recommendation was based on observational studies and on the average volume of fluid administered prior to patient randomization in the ARISE, PROCESS, and PROMISE trials, and of which fluid resuscitation was a main component. Of note, none of these 3 trials found any clinical benefit of the early goal-directed treatment regimen that this fluid administration was part of. Since the adoption of this volume recommendation by guidelines, as well as CMS core measures for septic shock management, there's been a lot of criticism for trying to make patients fit into a one-size-fits-all model by requiring at least 30 mils per kilo of fluid as a fixed volume for all patients with septic shock. One of the biggest arguments is that overloading patients with fluid can actually cause harm, particularly for patients with CHF who may present as a mixed sepsis and cardiogenic shock picture, as well as patients with end-stage renal disease. To date, there are no randomized controlled trials to compare different volumes for initial resuscitation in sepsis or septic shock. There have been a few observational and retrospective studies since the 2016 guidelines were published, which has suggested that time to completion of a 30 mil per kilo bolus does not impact in-hospital mortality, and some evidence that large volume resuscitation with more than 5 liters of fluid may actually increase mortality. However, what was surprising to me is that there's only one article referenced in the 2021 guidelines section on this recommendation, and it was a single-center retrospective study published by Dr. Kitab and colleagues in critical care medicine in November of 2019. They included 500 patients with sepsis, half of whom received the 30 mil per kilo bolus within 3 hours and half of whom did not. They found that patients who did not receive the bolus within 3 hours had increased mortality, delayed resolution of hypotension, and increased ICU length of stay regardless of their comorbidities, including those populations deemed at higher risk of harm from fluid overload, including end-stage renal disease and heart failure. And actually, more patients in the group who did not receive the bolus within 3 hours did have end-stage renal disease and heart failure. So taking all of this conflicting data into consideration, what exactly changed in the 2021 sepsis guidelines on this front? Well, to be honest, mostly verbiage and a level of evidence grading. The newest recommendation reads that for patients with sepsis-induced hypoperfusion or septic shock, we suggest that at least 30 mL per kilo of IV crystalloid fluid should be given within the first 3 hours of resuscitation with a weak, low quality of evidence rating. So what was downgraded here was the verbiage of recommending 30 mL per kilo to suggesting this, and the previously strong, low quality of evidence has been downgraded to weak, low quality. In the discussion of these changes, the 2021 guidelines state that in order to avoid over and under resuscitation, fluid administration beyond the initial resuscitation should be guided by careful assessment of intravascular volume status and organ perfusion. While this may not seem like a big deal, this downgraded bullet point in the guidelines does have some big implications. The biggest one that I saw coming up in the Twitterverse was just praise from emergency medicine providers who feel like this update gives them the freedom to use their discretion and clinical exam findings to determine hydration status rather than assuming dehydration secondary to infection. In addition, this downgrade in evidence and wording may have implications for reimbursement and compliance metrics with CMS standards, whereas currently patients who are fluid overloaded at baseline have to get that full 30 mL per kilo in order to be compliant with that core measure, even though giving that much fluid may actually be harmful. Ultimately, more data is needed to determine how much fluid should be given in the initial sepsis resuscitation phase and whether the risk versus benefit ratio of a one-size-fits-all approach is favorable for patient populations in which fluid overload can be especially detrimental. But until then, the ball is back in the court of providers to use their clinical judgment to determine patients' fluid statuses and how much fluid is optimal in sepsis resuscitation.
This seems like the rare change that both sides will probably be very unsatisfied with this, because if you're pro 30 mils per kilo for everybody, then you feel like the evidence is there. Why would we downgrade it? And then if you're against it, it feels like, yes, you made a change, but it was subtle enough that how much practice change is actually going to happen. So this is a kind of a unique change. I think it's also of note, you have to dive into the text to see this, but they suggest using ideal body weight for kind of your resuscitation. So maybe easier to squeeze by for those patients where fluid might be a bad thing. The other thing, Alyssa, you did a great job of highlighting that it's really based on this one study. The other thing that I thought was very notable when you look into these guidelines, they also use the Process, Arise, and Promise studies, the 3 landmark septic shock studies, and they say that because most of those patients receive 30 mils per kilo, it suggests that this fluid volume has been adopted in clinical practice. So we should just continue doing it, is my interpretation of that, which is one of the things I dislike. So really a great in-depth discussion on Alyssa, but I don't think either sides are satisfied here.
Yeah, I agree with you.
Now, speaking of a very starting as an unsatisfactory recommendation, going into one that people may like a little bit more, Sara, why don't you discuss how the new guidelines mention Q-SOFA?
Yeah, so one of the new recommendations in the updated surviving sepsis guidelines from 2021 is related to the screening tools utilized when evaluating patients with possible sepsis. This brand new recommendation, which is a strong recommendation based on moderate quality evidence, states that the authors recommend against using Q-SOFA or quick sequential organ failure assessment compared with SIRS, or systemic inflammatory response syndrome, NEWS, National Early Warning Score, or NEWS, Modified Early Warning Score, as a single screening tool for sepsis or septic shock. Defining sepsis centers around organ dysfunction, and for this purpose, the Sepsis 3 Task Force designed and endorsed the use of the Q-SOFA score. Q-SOFA utilizes 3 variables to predict death and prolonged ICU stay in patients with known or suspected sepsis, those being altered mental status or a Glasgow coma score less than 15, respiratory rate greater than or equal to 22 breaths per minute, and a systolic blood pressure less than or equal to 100 millimeters mercury. If any two of these are positive, patients are considered Q-SOFA positive. Recently, newer data has shown to be contradictory to the usefulness of Q-SOFA, with evidence of poor sensitivity of this screening tool. One of the supporting pieces of literature for this new recommendation in the guidelines is an article published in Chest by Rodrigo, Serafim, and colleagues titled A Comparison of Q-SOFA and SIRS Criteria for the Diagnosis of Sepsis and Prediction of Mortality. This was a systematic review and meta-analysis that evaluated studies published after the Sepsis 3 publication that came out in February of 2016, which proposed the use of Q-SOFA. The aim of this review and meta-analysis was to compare Q-SOFA and SIRS, as well as their sensitivity and specificity in diagnosing sepsis, hospital and ICU length of stay, as well as mortality. 10 studies, 8 of which were retrospective and observational in nature, and 2 of which were prospective in nature, with 229,480 patients were included in this evaluation. It's important to note that one of the 10 studies enrolled 184,875 patients itself, which was about 80% of the patients included in this meta-analysis. 2 of the studies evaluated patients at ICU admission, with 8 studies evaluating patients in the emergency department setting. In-hospital mortality and sensitivity for the diagnosis of sepsis were the most frequently reported outcomes, and these studies included, with 1 study evaluating the specificity of sepsis diagnosis. Overall, the authors concluded from their meta-analysis that SIRS was found to be more sensitive than Q-SOFA with regards to the diagnosis of sepsis. As a matter of fact, SIRS was significantly superior to Q-SOFA for the diagnosis of sepsis. Q-SOFA, on the other hand, was in fact favored as a predictor of in-hospital mortality based on the meta-analysis of 7 of the 10 studies included in this systematic review. In the 1 study included in this analysis that evaluated the specificity of diagnosing sepsis, Q-SOFA was favored. Looking at some strengths and weaknesses of this study, they did include a large population of patients from the 10 studies that were included, and the authors did note a low risk of bias in most of the studies, according to the Newcastle-Ottawa Scale Quality Assessment. And there also was a larger sample size in this review than the original Sepsis 3 study. However, on the other hand, these were mostly observational studies with noted heterogeneity, and the studies included in this evaluation had different criteria for diagnosis of sepsis. Most of the studies were in fact designed to describe predicted mortality of SIRS and Q-SOFA, and not so much diagnostic accuracy, which we know as a result, Q-SOFA seemed to be better in terms of being a predictor of in-hospital mortality. Data on length of stay, additional costs, or long-term outcomes were unable to be assessed. Overall, as we still don't have a gold standard for the diagnosis of sepsis, it's important to keep in mind that the diagnosis is dependent on clinical and lab data, notably presentation and evidence of systemic illness, evidence of organ dysfunction, and microbiologic data. The key takeaway is that the noted lower sensitivity of Q-SOFA from the results of this study is concerning in the sense that there may be delays in identifying and treating sepsis in a timely fashion. So these results make sense in terms of the revised guideline recommendations for a single screening tool for initial sepsis diagnosis. Conversely, the increased sensitivity from SIRS may lead to possible overdiagnosis of sepsis and eventual possible overuse of antibiotics. I think applicability to practice depends on what the current habits or culture is at one's institution. For example, at my institution, most, if not all, providers do utilize SIRS criteria when evaluating patients for sepsis. So this updated recommendation most likely won't affect current practice, and it may just act as a reminder that what they're doing is still supported by evidence-based guidelines.
The irony here is that the Q-SOFA was introduced because of the sensitivity of SIRS, right? We all remember being taught how many things mimic it, right? How many of our teachers made the joke that they would meet the SIRS criteria just from climbing up 3 flights of stairs, right? And so then they recommended the Q-SOFA and then found that it's actually less sensitive. So it's really another example of things that in theory sound great, but in practice doesn't necessarily work out. I think this was so universally disliked by most people that at least the organizations I've all worked at continue using the SIRS criteria as well. You know, you mentioned that's what your institution still does. So that makes sense. Now everyone knows that this podcast is a balanced solution. We are pro balanced solutions. We are against abnormal saline, and I'm going to lead the way to Alyssa to join us back because I feel like the sepsis guidelines may have joined our team.
I think you are correct in that assessment. So we started out our sepsis discussion here talking about how much fluid we're giving in sepsis, but one of the other big recommendations in the guideline revolves around which fluids we should be giving. So while crystalloids remain the first line fluid of choice for resuscitation, one of the big new highlights in this guideline is that for adults with sepsis or septic shock, balanced crystalloids are now suggested over normal saline. Crystalloids were first recommended as the fluid of choice in sepsis management in the 2012 sepsis guidelines, and they've remained the fluid of choice since then. However, in recent years, concerns have been raised regarding the potential adverse effects associated with unbalanced crystalloids, namely, as Nick said, abnormal saline. These include hyperchloremic metabolic acidosis, renal vasoconstriction, increased cytokine secretion, and concerns for AKI. And this has led to the publication of a handful of randomized controlled trials since the last sepsis guidelines were published in 2016, focused on identifying whether balanced solutions such as lactated ringers or plasmolite may confer benefits over chloride-rich saline. The three trials discussed in the 2021 sepsis guidelines are the SPLIT, SALT, and SMART trials. SPLIT was the first of these to be published in 2015, a multi-center, double-blind, randomized trial comparing balanced solutions to normal saline in about 2,200 ICU patients. They found no differences in mortality or AKI. However, only 4% of patients in the study were septic, which makes it difficult to generalize these results to this population. Subsequently, we saw the publication of the SALT trial in 2016, which also compared balanced fluids versus normal saline, and of which more than 25% of their nearly 1,000 patients presented with sepsis. One of their outcomes was major adverse kidney events within 30 days, also called the MAKE-30, which is a composite endpoint of mortality, new renal replacement therapy, or persistent renal dysfunction. In the end, the SALT trial found no difference in MAKE-30 between fluid types, with this endpoint occurring in 24% of both groups. Finally, the guidelines discussed the SMART trial, which was published in 2018. This was a single-center, unblinded, pragmatic randomized controlled trial in which they used cluster randomization, alternating between randomizing ICU patients to receive balanced solutions versus NS on a monthly basis. They analyzed data from 15,000 critically ill patients, and their primary outcome was also the MAKE-30 composite endpoint. Their secondary clinical outcomes included 30 and 60-day in-hospital mortality, ICU-free days, ventilator-free days, vasopressor-free days, and days alive and free of renal replacement therapy during the 28 days after enrollment. Sepsis was the admitting diagnosis for about 15% of patients in each group, and in their pre-specified subgroup of those patients admitted with sepsis, 30-day mortality was 4% lower in patients who received balanced solutions. Additionally, in their secondary analysis of patients admitted to medical ICUs with sepsis, balanced solutions were associated with lower 30-day hospital mortality in MAKE-30 and increased vasopressor-free days and days free of renal replacement therapy. Based in large part on these three studies, the 2021 sepsis guidelines conclude that the use of balanced solutions in sepsis may be associated with improved outcomes. However, given the low quality of evidence, they made this a weak recommendation. They also noted that there have not been any cost-effectiveness studies comparing balanced versus unbalanced crystalloids, which may be important to consider given the historically higher cost of products like plasmolite. In terms of real-world implications for this guideline update on choice of fluids, I'm interested to see what happens. I informally polled several of my provider friends who work in EDs and ICUs all over the country just to see whether this updated recommendation had changed their practice at all. Mm-hmm. And to be honest, I was kind of surprised by the variety of answers that I got. I had one friend who said they've been using balanced solutions for sepsis for years and couldn't even remember the last time they bolused someone with NS. I had other friends who shared that their practice site continues to lean on NS as their workhorse in sepsis, and still others who said they've historically leaned on balanced solutions but not really had strong feelings about it, who now are making a more conscientious effort to use balanced solutions for patients who present with suspected sepsis. So I think it'll be interesting going forward with the adoption of these guidelines to see whether the landscape across institutions becomes a little more homogeneous.
Now, knowing that this is a completely biased question, at least from my perspective, Alyssa, what are your thoughts on kind of fluids and abnormal saline versus balanced solutions?
Yeah, so personally, it's never made a lot of sense to me from a physiologic standpoint to use NS for patients who are requiring boatloads of fluid. I've always been more in the camp of like, why not use a fluid that more closely mimics our body's electrolyte composition? But as we know, theoretical medicine doesn't always translate into outcomes. I think it's really important that this is being more widely studied and that we're starting to have that outcomes data to guide our decisions on fluid choice and support that rationale.
I mean, I'll still have providers telling me, because the DKA guidelines were last updated in like 2009, that we should be using normal saline in those patients. I mean, it feels like we should just be moving really outside of maybe neuro patients. We could just be doing balanced solutions for everybody, but I guess we'll let the evidence weigh out and see if that's the route we're going or not. Now, I'm going to link Sara back in. It's kind of a timely recommendation that our ID and stewardship clinical pharmacist is going to discuss regarding antimicrobial treatments in sepsis.
Yeah, so getting a little bit into how we manage infection and identifying patients with possible infection and sepsis, I did want to review some of the other revised recommendations from the 2021 sepsis guidelines update. So getting into an important thing, especially in my mind, is timing of antimicrobial therapy. So in the 2016 rendition of the sepsis guidelines, what they recommended was administration of intravenous antimicrobials should be initiated as soon as possible after recognition and within 1 hour for both 1, septic shock, and 2, sepsis without shock. Importantly, this was a strong recommendation based off moderate quality of evidence. Interestingly, in the 2021 rendition of these guidelines, this recommendation was revised to state, for adults with possible septic shock or a high likelihood for sepsis, we recommend administering antimicrobials immediately, ideally within 1 hour of recognition. So there's a little bit of a change in the language behind that. And the strength and quality of evidence was a little bit of a downgrade. So again, it stayed a strong recommendation, but for septic shock specifically, it was downgraded to a low quality of evidence. And for sepsis without shock, it was downgraded to a very low quality of evidence, but still strong recommendation. So I wanted to review one of the articles published by Lou and colleagues from Kaiser Permanente in California. That was one of the supporting articles behind this recommendation, revised recommendation into the timing of antimicrobial therapy. So this study was conducted in order to evaluate for an association between timing of antimicrobial therapy and mortality among patients with documented sepsis, particularly patients who received antibiotics within 6 hours of emergency department registration. This is a retrospective study of 35,000 patients with sepsis from 21 different emergency departments, or EDs, across the state of California from 2010 to 2013. Patients were stratified according to sepsis severity, with that being sepsis, severe sepsis, and septic shock, with those with septic shock requiring vasopressor therapy. Of note, there were 18,210 patients in severe sepsis, a little over 12,000 in septic shock, and about 4,700 with plain sepsis. The mean age of our patients in this study was about 73 years of age, split about 50-50 male and female, and about 20% of the patients were admitted to the ICU after being seen in the ED. Of note, 73% of the patients were a full code. The primary endpoint in this study was adjusted in-hospital mortality, which was adjusted for each hour of delay of antimicrobial therapy. The investigators also looked at median time to antibiotic administration. Getting into the results of the study, what they found was, again, that median time to antibiotic administration was noted to be about 2.1 hours, and time to antibiotic administration was noted to be shortest in the septic shock group, which makes sense, with a median of 1.7 hours to administration. And interestingly, it was longest in those in the sepsis group, with a median of 2.3 hours. This was noted to be statistically significant. When looking at the antibiotics that were administered, about 42% of patients received only one solitary antibiotic, with the most common antibiotic given being ceftriaxone, interestingly. The frequency of receiving 2 or more antibiotics increased as severity of illness increased. For example, 52% of patients with sepsis received multiple antibiotics, compared to 71.7% in the septic shock group. This was also noted to be statistically significant. When looking at the primary outcome of the adjusted in-hospital mortality, they found an odds ratio for that in-hospital mortality based on each hour of antibiotic delay. It was found to be 1.09 for each elapsed hour, so about a 9% increase. Again, each hour of delay of administration essentially was associated, again, with that 9% increase in mortality, with the greatest benefit seen when antibiotics were given within that first hour. The takeaway from this study is that early antibiotics should be given as soon as possible, especially for our patients who are diagnosed with septic shock and meeting that criteria. However, mortality may not be as great if there are delays in those in which you may be less certain to have a sepsis diagnosis. Again, this study included a large population of over 35,000 patients, and patients were stratified by very minute and granular details to stratify them into each of their cohorts, ranging from sepsis to severe septic shock requiring vasopressors. Again, this study unfortunately does not answer all the questions about timing of therapy. It just supports that earlier when given is better, especially for those who are the sickest patients with septic shock. Additionally, the investigators did not account for other therapies that patients may have received, such as fluid resuscitation, again, considering what other agents patients might have received within that first hour. So is it really the antibiotics doing the legwork, or is it a combination of the multiple remedies given early in hospital presentation?
Mm-hmm. So I guess the question for you, Sara, would be, do you think kind of from what you've known and looked at with this, do you think the evidence kind of supports this change going back from 1 hour for everybody?
So I think the 1 hour for the sickest patients with septic shock, yes, definitely. Mm-hmm. I think that is something to consider. But I can see where, and even looking at some of the other studies that went into this recommendation, where our patients were not quite sure if they're meeting that sepsis criteria, or they, were just classifying them as having sepsis, not necessarily shock or severe sepsis. I can see where I don't think that first hour is as pertinent as, again, looking at that for our sickest patients.
Yeah, I completely agree. And I think unless you've worked in an ED or kind of been in that kind of high acuity, high volume area, an hour sounds like a lot, but in the scheme of dealing with someone that's really sick with sepsis, it can feel very quick. So kind of elongating that for our less sick people, or for the people, right, that meet our SIRS criteria, and we don't know if they have sepsis or not, right? We don't have to be worrying at minute 45 if we're slamming in those antibiotics or not.
I agree. Yes, an hour can come and go very quickly.
And for Alyssa's third study, she's going to kind of come back in and talk to us about something that a lot of us may have been doing in practice that the guidelines now kind of bring up and support.
Yeah, so some of the other new recommendations in the 2021 sepsis guidelines relate to vasoactive management. While norepinephrine remains the first-line vasopressor for septic shock, the new guideline offers a more stepwise approach to when and what vasopressors to add if full MAPs can't be achieved with norepinephrine alone. Whereas the 2016 guidelines suggested either vasopressin or epinephrine could be added to norepi to raise MAPs to goal, the new guidance suggests that for adults with septic shock on norepi with inadequate MAPs, vasopressin should be added instead of continuing to escalate the dose of norepi. If MAPs are still inadequate on both norepi and vasopressin, then they suggest adding epinephrine. The rationale for making epi a third-line agent is based on the idea that targeting the same receptors as norepinephrine may be of limited utility, so vasopressin may be more adequate in this scenario. However, existing outcomes literature has not found a significant difference between epi and vasopressin in terms of mortality when either is used as a second-line agent. Another of the interesting vasoactive recommendations pertains to the route via which we're giving them. So a new suggestion in the 2021 guidelines is that vasopressors should be started peripherally to restore MAPs rather than delaying initiation until central venous access is secured. One of the studies discussed in the guideline was published in 2020 as a post-hoc analysis of the ARISE trial. And this was a retrospective cohort study which included all patients who received a vasopressor infusion for at least 30 minutes from ED presentation to 6 hours post-randomization. And their primary outcome was all-cause mortality at 90 days. In total, they looked at 937 patients, and they found that 42% had early vasopressors initiated via a peripheral line. There was no difference in mortality between patients who were initiated on peripheral versus central line pressors. However, they did notice that patients who received peripheral pressors had a shorter time to initiation by about 2.5 hours, and most of these patients were able to achieve a MAP greater than 65 within 1 hour. While the study found no difference in mortality between peripheral and central pressor groups, other studies have found that delays in vasopressor initiation and achieving MAPs above 65 may be associated with increased mortality. Something also important to note about this study is that the median duration of peripheral pressor use was only just over an hour. So this really was a temporizing measure in the ARISE trial until central access could be obtained, which I think contributes to the external validity of these findings, as this is most commonly why we start peripheral pressors, at least in the institutions that I've been in. However, a 2015 meta-analysis also referenced in the guideline found that administration of vasopressors via a peripheral catheter proximal to the antecubital fossa was unlikely to cause local tissue injury when infusing vasopressors for less than 6 hours. This is mentioned in the rationale under the guideline recommendations for monitoring and IV access, although the authors of the guideline do not recommend any specific time limit on how long peripheral pressors should be used before switching to central access. They only say that if pressors are still needed after a short period of time, they should be switched to central venous access as soon as is practical. Personally, the institutions in which I've trained and practiced have always been okay with starting peripheral pressors when necessary to expedite getting MAPs to goal for patients with sepsis, and then switching to central access later if there's a continued need for pressor support, generally at the 24-hour time mark. So while it's nice to have the support from the guidelines in writing, I'm not sure how much this is really going to change. Some things that I think will be interesting to see data on moving forward are further definition of the time constraints for using peripheral pressors, and also the use of midline catheters for vasopressors and what outcomes data says regarding their safety in comparison to your traditional peripheral or central line.
Yeah, I completely agree with what you're saying, Alyssa. I'm not sure how much this is going to change people's practice habits per se. Patrick Vieruszewski came on and was talking about the time to our MAP improvement is important, right? So getting these vasopressors initiated peripherally to get our MAP goal up in a timely fashion is a really good thing. Now, the only thing I want to highlight, because we use peripheral vasopressors as well, I have for years and years, but I always pay very important to the IV, the peripheral IV itself. Our informal protocol at one of the places I've trained was it needed to be 18 gauge or lower, so like a bigger IV, and it couldn't be in the hand. It had to be at the antecubital or above. So kind of doing all that we can to prevent extravasation. When you kind of look at the table 2 in the study or the review you were mentioning, most of the incidents are not reported what gauge it is, but if you look at the ones that did, almost everything is in gauges 20, 22, and 24. So I think the devil's in the details here. So just be careful if you're in the ED and you have somebody who's getting a 24 in the hand from EMS and you're going to start 2 pressors there. I would exercise caution before we do that, but I think that's a really good kind of study to highlight. If you haven't been doing this, this may be a new therapy for you to kind of get involved with at your institution. And then closing out our sepsis 6-pack here, Sara, come back in and give us a discussion into our empiric MRSA coverage in the sepsis guidelines.
Yes. So I want to review one of the newer recommendations in the 2021 rendition of the sepsis guidelines, which is near and dear to my heart as an antimicrobial stewardship pharmacist. So previously in 2016 guidelines, what the author suggested is recommending empiric broad spectrum therapy with 1 or more antimicrobials for patients presenting with sepsis or septic shock to cover all likely pathogens, including bacterial and potentially fungal or viral. And this was a strong recommendation based on moderate quality of evidence. So the newer recommendation in this most recent rendition is for patients with sepsis or septic shock at low risk of methicillin-resistant Staph aureus or MRSA, they suggest against using empiric antimicrobials with MRSA coverage as compared with using antimicrobials without MRSA coverage. Interestingly, this is a weak recommendation based on low quality of evidence. I think that might be because it might be an up-and-coming thing and, some more data needs to come out. But so I'd love to review, one of the articles that went into supporting this newer recommendation. And this was published in 2020 in JAMA Internal Med by Barbara Jones and colleagues. And this article was titled Empirical Anti-MRSA versus Standard Antibiotic Therapy and Risk of 30-Day Mortality in Patients Hospitalized for Pneumonia. And obviously, concern over resistant organisms has led to the use of broad-spectrum antibiotics for pneumonia as well as other infections. However, the association with empiric anti-MRSA antibiotics and outcomes in high-risk patients with pneumonia is not well known. This was a retrospective multi-center cohort study that evaluated patients hospitalized for community-acquired pneumonia from 2008 to 2013 in the VA health system. And the objective of this study was to compare 30-day mortality among patients receiving empiric anti-MRSA antibiotics, which is defined as either vancomycin or linezolid, versus standard antibiotic regimens for community-acquired pneumonia, which was defined as receipt of either a beta-lactam and macrolide or beta-lactam and tetracycline combination or respiratory fluoroquinolone, such as levofloxacin. So the primary outcome that they evaluated was all-cause mortality within 30 days of hospitalization. Interestingly, there was a subgroup analysis of patients who were in the ICU, patients who had documented MRSA risk factors, patients with positive MRSA nasal PCR screens, as well as those with positive MRSA on an admission culture. Investigators also used a weighted propensity score matching analysis to control for patient characteristics possibly associated with both propensity of treatment and as well as risk of 30-day mortality. Over 88,000 patients were analyzed, with roughly 38% or a little over 33,000 of these patients getting anti-MRSA therapy. Breaking this down, about 40% of the patients received empiric anti-MRSA in addition to the standard of care community-acquired pneumonia antibiotics. On the other hand, about 60% received only empiric anti-MRSA antibiotics. Not surprisingly, about 98% of the patients who received anti-MRSA therapy received vancomycin. Those who received anti-MRSA therapy were generally patients with more comorbid conditions, those with more risk factors for MRSA infection, and had a greater illness severity, and this was based on the pneumonia severity index. Although propensity for treatment overlapped amongst the groups evaluated, which is important to consider. Empiric anti-MRSA therapy was significantly associated with an increased adjusted risk ratio of death, as well as kidney injury and vancomycin-resistant enterococci infections. When they evaluated that subgroup that I mentioned, about 16% of the patients were admitted to the ICU, and 2% of all patients had MRSA detected on clinical culture, which is interesting to note. There was a significant increase in 30-day mortality associated with anti-MRSA in addition to standard of care CAP antibiotics or community-acquired pneumonia antibiotics versus those standard of care antibiotics alone for those patients in the ICU. However, there was no significant difference in risk of mortality in those with MRSA found on clinical cultures, which would make sense because majority of them were receiving therapy. Overall, empiric anti-MRSA therapy was not associated with reduced mortality for any group of patients hospitalized with pneumonia, even in those with risk factors for MRSA, and these results contribute to additional evidence that questions the value of empiric anti-MRSA therapy, specifically, again, in this discussion for the indication of pneumonia. One thing to consider with this study is that it evaluated patients with community-acquired pneumonia only, as opposed to also including patients with other infections, such as bloodstream infections or ventilator-associated pneumonia and so on, which I think might limit the validity. However, on the other hand, it is important to consider that some patients, we have tons of patients actually that are admitted to the ICU with severe community-acquired pneumonia. So again, that kind of brings back the generalizability of this study. Additionally, only 40% of the patients who received anti-MRSA antibiotics received them with the standard of care community-acquired pneumonia antibiotics. So 60% of the patients, again, as I mentioned, received only those anti-MRSA antibiotics, which might explain why there might have been some increased mortality seen, as they might not have had appropriate guideline-driven coverage for community-acquired pneumonia. Given that this was retrospective, we also don't know what other variables might have contributed to mortality seen and we are unsure of how long anti-MRSA antibiotic therapy was on board. One thing that's interesting to note, again, as I mentioned previously, only 2% of the patients in the study actually grew out MRSA on cultures. Particularly, again, these were sputum cultures. However, clearly many more patients were exposed to anti-MRSA antibiotics, showing that they probably, again, most likely were unnecessary. However, this is not surprising either, considering they only included patients with community-acquired pneumonia. Again, Staph aureus is an organism that we do worry about, but not one of the typical classic community-acquired pneumonia organisms like a strep pneumo, for example. Lastly, it's unclear how many of these patients met sepsis criteria, kind of thinking of the bigger picture with regards to these revised guideline recommendations. From my perspective, again, as an antimicrobial stewardship pharmacist, I find this data very applicable and something to consider discussing with clinicians when taking care of patients. Often, in hindsight, when reviewing patients, we know that patients often end up receiving unnecessary antibiotics. So again, considering pertinent patient history, such as whether maybe if they had a history of MRSA infection or colonization, as well as considering presumed source of infection, which again with this study would have been respiratory, is important to consider, again, in general, when initiating antibiotic therapy.
Yeah, I loved your analysis here. I think that this may make the argument a little easier for the patient that maybe has sepsis, but we're going to give them vancomycin for 10 days just to be sure. Hopefully, we can maybe reduce the amount that happens. Honorable mention here, because we were only able to hit 6 of them, and I think they're. Listen, Sara really hit, to me, some of the most high points there in terms of recommendations. But just a couple other kind of honorable mention highlights is corticosteroids. Basically, they used to recommend only adding if you were unable to achieve your MAP goal with vasopressors, and now they suggest using corticosteroids if you just have an ongoing requirement for them. So kind of thinking about, right, we know corticosteroids reduce your time on vasopressors, so it makes sense that the guidelines kind of reflect that. And then for adults with septic shock and hypoperfusion-induced lactic acidosis, they suggest against using sodium bicarb to improve hemodynamics. So the fix-all Band-Aid, they don't recommend. Now, the recommendation right below it says that if your pH is less than 7.2 and you have some AKI, they suggest using sodium bicarb. I think this is the first time that they've really differentiated between the two. So again, more to come on this pod from the sepsis guidelines, but I thought that was a really good kind of summary of some of the big changes. All right, so we finished the sepsis 6-pack. Now we're gonna go to the In My Blood section and kind of talk about articles that are focused on infectious diseases. So Sara, don't go anywhere. We're gonna kind of hit some of your articles here for a second. And why don't you kind of take the lead on some of the infectious diseases focused articles?
Yeah, so I know we're transitioning into an infectious disease section, but this first article I want to review, keeping in theme with our sepsis theme, reviews the use of aztreonam, which is our monobactam antibiotic, in patients with sepsis. So currently, as we know, there's limited data comparing aztreonam, comparing them with anti-pseudomonal beta-lactams, again, such as our piperacillin tazobactam or cefepime, as empiric therapy for sepsis. To provide some answers to this question, Rupal Jaffa and colleagues from Atrium Health Carolinas Medical Center conducted the following study titled Empiric Aztreonam is associated with increased mortality compared to beta-lactams in septic shock. So I kind of already like where this is going. This was a multi-center retrospective cohort study of 582 patients admitted with septic shock. The primary endpoint that they evaluated was in-hospital mortality. And of note, a large majority of the patients in the aztreonam group, unsurprisingly, had a beta-lactam allergy. When evaluating the primary endpoint of in-hospital mortality, aztreonam, when given to patients with sepsis, was in fact associated with an increase in hospital mortality compared to our anti-pseudomonal beta-lactam. And there was about a 22.7% of mortality versus about a 13% rate of in-hospital mortality with our beta-lactam agents. And this was found to be statistically significant. The use of aztreonam was also associated with use of additional antibiotics within the first 24 hours, such as aminoglycosides and fluoroquinolones. Interestingly, about 24% of the patients who received ACE-TRANAM initially ended up getting a beta-lactam as their second agent for gram-negative rod coverage. I find that fascinating. And overall, about 38% of the patients who were on ACE-TRANAM ended up getting switched to a beta-lactam during their hospitalization. One other thing to note, about 15% of the patients in the ACE-TRANAM group and 25% of the patients in the beta-lactam group did have a bacteremia noted on admission. And interestingly, in over half of those 15% of the patients in the ACE-TRANAM group ended up having a gram-positive bacteremia, which again, we know ACE-TRANAM does not provide coverage for. So again, strength of the study, they evaluated the sickest patients, patients coming in with septic shock. Again, it was a smaller retrospective study looking at a smaller patient population. We're not quite sure, how the antibiotics were dosed. Again, as we know, often with like our anti-pseudomonal beta-lactams will provide extended infusions. Did the use of some of the other agents like aminoglycosides and fluoroquinolones in that ACE-TRANAM group possibly mask, any further mortality? That remains to be seen. And, we're, again, kind of a general question, but, were there any other factors contributing to mortality that were not discussed? So overall, this is good data to know. And it's an important reminder to consider spectrum activity and using your local antibiogram when choosing agents for empiric therapy for sepsis.
And we need to verify those allergies. She said it's fascinating that they got beta-lactams. I can think of a few adjectives I'm going to keep to myself on it. People getting beta-lactams. In my mind, what I envision is somebody started them, and then one of our pharmacy colleagues actually verified the article, and someone's amoxicillin-induced nausea was deemed not a significant reaction, and we were able to get those switched. But yeah, really an interesting article. I mean, they got longer time to treatment, more bugs were uncovered. So kind of fascinating here.
Yeah. And I think, again, like you mentioned, just another good reminder to really reevaluate those antibiotic allergies.
Now we've, one of the things with antibiotics to kind of prevent we try to reduce their use because there can be some adverse effects that can come from it. So Sarah, what's another article talking about one of those adverse effects?
Yeah, so as we know, Clostridioides difficile, or C. diff, and again, I want to emphasize the new nomenclature, is one of the most common adverse events from our broad spectrum antibiotic use. Again, especially associated with later generation cephalosporins, beta-lactams, fluoroquinolones, and so on. So again, as we know, C. diff is an urgent threat to public health. Especially this was documented in the 2019 CDC Antimicrobial Resistance Threats Report. So preventing C. diff, and excuse me for my colloquialism, but especially, primary infection with C. diff, it is a high priority for hospitals. The use of probiotics to prevent primary C. diff infection has been based on the premise that good bacteria from the probiotics is thought to re-inoculate the GI microbiome that has been disrupted by antimicrobial use. So this study that was published by Emily Heil and colleagues in Clinical Infectious Diseases was a quasi-experimental pre-post study that evaluated the impact of a computerized clinician decision support tool to prompt the ordering of probiotics at 4 hospitals within the University of Maryland Medical System. There was a best practice advisory, or BPA, that was set up to alert providers to order BioK specifically at the first order of a qualifying high-risk broad-spectrum antibiotic. Hospital-wide C. diff incidence was evaluated in the pre- and post-time periods, which were both 13 months in length. So what did they find? Overall, what they found was that quarterly C. diff incidence actually increased over time in the post-intervention cohort compared to their baseline trends. And patients who received probiotics did not end up having lower rates of C. diff compared to those who were eligible to receive probiotics but ultimately did not receive them for whatever reason. So overall, the big summary of the study is that the results do not support the use of probiotics, specifically BioK, which again is what my institution uses, to prevent primary C. diff infection in hospitalized adults.
So what's your current practice? Like, do you use probiotics for kind of, super infection prevention?
So we do have institutional guidelines for treatment and prevention of C. diff. And for our prevention section, we do mention the possible use of probiotics. I will admit, I think it varies from clinician to clinician. Is it something that I endorse? Not so much. One of the other things that we utilize is prophylactic oral vancomycin, 125 milligrams daily. That is something I think that we, probably endorse definitely more than probiotics. But again, that also, I think, has a lot of data that is a little bit questionable and not the most robust in supporting that practice either.
No, but I would say that the data is better than it is with probiotics, though. Absolutely. I would agree that it's not 100%. Yeah, it's kind of a rough stretch for probiotics here because there was during this time period, there was a study released in JAMA looking at probiotics for VAT prevention, and no difference was found in this big multi-center study looking at over 2,500 mechanically ventilated ICU patients. So the other guideline of note, I'm sure this already sent shockwaves through the ID communities. I know I remember the specialists I work with talking about it, but the C. diff guidelines were published as well during this time frame. And I remember the first time I heard that they suggested fidaxomicin as first-line use, I remember everyone getting really fired up about that. So we won't get into that here, but it's kind of a couple other articles to highlight here. So Sara, go ahead and end our kind of in my blood section and give us the last kind of good New England Journal of Medicine review you were able to find.
Yeah, so kind of shifting gears and getting to another area of infectious disease that I wanted to quickly review and thought was really informational was a review article, as you mentioned, published in the journal by Thompson and colleagues that reviewed Aspergillus infections. So as we know, Aspergillus spores are ubiquitous in the environment, and disease can manifest after exposure and inhalation, again, especially in certain populations. The clinical spectrum of disease manifestation is variable, and obviously, as we know, depends on host immune response. So again, this was a review article that really kind of focused on reviewing the various facets related to infection with Aspergillus, as well as ways to manage. So when reviewing, some of the epidemiologic factors and host immunity factors with Aspergillus infection, those at the highest risk of infection include our immunocompromised, such as our oncology and heme-onc, bone marrow transplant patients on immunosuppression. It also includes our patients that are admitted to the ICU, although admittedly there are many variables at risk at play, such as ARDS. Other patients at risk, are patients diagnosed with severe respiratory viral infections, such as our friend COVID, as they damage the pulmonary epithelium. When evaluating actual infection and disease with Aspergillus, severity of infection is inversely correlated with host immune status, as I just reviewed. There is a wide array of clinical manifestations of disease, ranging from cutaneous or sinus infections to that of invasive aspergillosis. What diagnostics do we use when evaluating patients for infection with aspergillosis? So we have our galactomannan, which really is useful when we obtain from serum as well as bronchoalveolar lavage samples if we're concerned for pulmonary infection. And again, these can be utilized in certain populations. The other option would be beta-D-glucan, but the issue with beta-D-glucan is that it's not specific to Aspergillus. So again, galactomannan is a little bit better in that respect. Ultimately, when reviewing our treatment options, voriconazole is our drug of choice, and clinicians should remain cognizant of drug interactions, as well as the genetic polymorphisms related to CYP2C19, which leads to the variable PK that we see with this agent, hence the importance of therapeutic drug monitoring. So again, this review provides an articulate overview of the management of Aspergillus infections, going from patient risk factors and diagnosis to treatment of infection. I think this article, can serve as a guide to new learners, and especially serve as a supplement to reviewing the IVSA guidelines with learners and residents, and helping them understand the variables behind management of patients with Aspergillus infections.
Yeah, I feel like it's a really good overview of everything without going into too much detail into one thing. So you kind of mentioned an intro to this kind of big topic for learners. I completely agree. And in these New England Journal reviews, they always have beautiful pictures and images, and I'm such a sucker for those. And Figure 2 does a really good job showing the various antifungal mechanism of actions, kind of based on the fungal cell. So I think that's really cool. There was a lot of good ID articles. Thank you, Sara. Definitely don't go anywhere. We're going to be bringing you back here in just a second. So Alyssa's going to take the lead on our next section, the ventilator blues. As everyone knows, we're kind of diving into our pain, agitation, and delirium articles. So Alyssa, why don't you kind of take us away, starting with the process of getting put on the ventilator?
Yeah. So when we think about putting people on the ventilator, for pharmacists, one of the first things that comes to mind for us is rapid sequence intubation. And one of the most commonly used induction agents for RSI is etomidate. Etomidate is great in that it has a quick onset of less than a minute. It has a short duration of only a few minutes, and it's not really associated with any cardiovascular side effects, which makes it a preferred anesthetic induction agent. However, one of the adverse effects that is associated with etomidate is adrenal suppression, and it's long been controversial as to how clinically relevant this effect is. So to further define the impact of etomidate-associated adrenal suppression, Drs. Stuart Albert and Sykuta conducted a meta-analysis which was published in the October issue of the Journal of Intensive Care Medicine. They looked at over 29 trials, including over 8,500 patients who received etomidate versus comparators, and their primary outcome was 28-day all-cause mortality. What they found was that adrenal insufficiency occurred at a risk ratio of 1.54, and for patients with a predicted mortality over 44%, the 28-day all-cause mortality was significantly higher, with a risk ratio of 1.2 and a number needed to harm of 12.5, which, when you think about, at least in my practice, the number of people who get etomidate for short procedures, is a pretty clinically significant number needed to harm. Now, there were some limitations to the study, namely that the primary studies included were mostly retrospective and post-hoc studies, but overall the authors concluded that yes, adrenal suppression appears to be a problem with etomidate that may negatively impact mortality, particularly in critically ill patients with high severity of illness. Personally, I do think this meta-analysis drives home the potential clinical impact that etomidate may have on our most critically ill patients when they present to us. While there's not really any positive evidence to suggest using supplemental steroids with etomidate to counteract this effect, at least for me, I think one easy thing we can do is just reconsider what we're using for induction agents when it comes to our sickest patients and consider turning to a different agent like ketamine instead if it's appropriate.
So as a person who's been involved with multiple RSIs, I'm assuming here, do you feel like this review kind of changes your practice, or were you doing this before you had kind of looked into this article?
Yeah, so to be honest, before I looked into this article, I don't think I had very strong feelings about it. I mean, there's really not a ton of outcomes data looking at the effect of etomidate-associated adrenal suppression. And so I thought this was eye-opening for me. I think in terms of my practice, at least with patients with septic shock who were intubating, and thinking about that population already being in a state of relative corticosteroid insufficiency, this article is a reason for me to stay away from etomidate in that particular patient population and consider using alternatives instead.
That you said you didn't have strong feelings before. I feel like this is the verbal meme of James Franco in Pirates of the Caribbean, where he's on the plank and he's saying first time, because we started off saucy here bringing up etomidate and adrenal insufficiency, because I'll just tell you, people have extremely strong feelings one way or another. It sounds like you're joining the no etomidate in sepsis train, which I see, I get it. I'm okay with that. I'm just letting you know that I'm on the opposite train. I'm just telling you, I see that. And there are different reviews that'll tell you different things. It does increase the risk. From my perspective, if a provider feels more comfortable with etomidate, and they want to use that, I don't necessarily die on that hill. But what I will do if they're hypotensive is maybe recommend adding some corticosteroids sooner than I maybe would in other scenarios, knowing if they got etomidate there. But yeah, welcome. As you're going to be in the emergency medicine crew, you gotta have strong feelings about that. So I'm glad you at least decided one way or the other. Now, let's go into something that I would say is much less controversial, and it's kind of how we administer one of our drugs for acute agitation.
Yeah, so when it comes to acute agitation in the ED and the ICU, we have a lot of tools in our arsenal. Systemic dosage forms are often preferred for acutely agitated patients, as it can be pretty difficult to get someone to swallow a tablet in these situations. And one of the systemic options that we have is olanzapine, which is FDA approved to be given via the intramuscular route for acute treatment of schizophrenia and bipolar disorder, and often used off-label to treat acute agitation not associated with one of those disease states. However, one of the drawbacks to IM olanzapine is that it can take up to 45 minutes to reach peak concentrations via this route. And if you've ever directly managed an acutely agitated patient, 45 minutes can feel like an eternity.
45 hours.
45 hours, exactly. So consequently, IV olanzapine has been proposed as a useful option for patients who have IV access, as it can be given more rapidly with quicker results. Unfortunately, there's limited data on the safety of this practice, which is where our next study from Dr. Hunt and colleagues in Annals of Pharmacotherapy comes in. This is single-center retrospective study included 252 patients who received a total of 1,247 administrations of IV push olanzapine at doses ranging from 1 to 10 milligrams. On an administration basis, about 8% of administrations were associated with one adverse event. Hypotension was the most common adverse effect, occurring after 5% of administration. Infusion site reactions and bradycardia were the next most common adverse events, occurring with 1.7 and 1.3% of administrations respectively. Respiratory depression, arrhythmias, akathisia, and dystonia all occurred in less than 1%. It's worth noting that all of these incidences were similar to or lower than those seen with IM olanzapine. But one limitation to bear in mind is that given the retrospective nature of the study, these findings do rely on accurate documentation for all of these administrations and subsequently documentation of any adverse events which occurred, which we know in chaotic situations where you're managing an acutely agitated patient, correct documentation may not occur 100% of the time. But I think the big takeaway still from this study, even though it's small and retrospective, is that IV push olanzapine does appear to be a safe route of administration for acute agitation. However, it will be important for future studies to look at the efficacy of this practice compared to IM administration or the use of other agents.
This kind of reminds me of a similar thought process of when the Mind USA study looked at IV ziprasidone, and before that we had always given IM. This seems similarly where, we have something that's typically given IM and we're finding data to give it IV. And like you said, right, all the PK properties make this really advantageous. So I know our colleagues in the ED and anybody that has the unfortunate responsibility of going to like behavioral alerts, or we've called them code greens and things before. This will be welcome news that we kind of have another route that appears to be just as safe when appropriate.
Yeah, absolutely.
Now the listeners know, our friends of the pod know, we generally avoid COVID articles in the literature review series, but there were a couple of good ones, and everyone knows, right? Rules are here to be broken, so we're going to bend them a little bit. So, Alyssa, let us know what's in our last Ventilator Blues article.
Yeah, so I'm totally on board with you in terms of trying to stay away from talking too much about COVID because there's its ugly head in every other part of our lives. But as we near the end of our second full year of the pandemic, we do continue to learn a lot about the different impacts of COVID-19. And if you've cared for many of these patients in the ICU, you might be able to anecdotally speak to the relatively high sedation requirements we've been seeing with COVID ARDS. And if you've ever thought like me, wow, it feels like these patients have way higher sedation needs than other ARDS patients, I do have a study, our last study, to affirm those feelings. So in September, Critical Care Medicine published a propensity-matched retrospective cohort study comparing 114 COVID ARDS patients with 228 non-COVID ARDS patients. Their primary outcome was in-hospital mortality mediated by a higher percentage of comatose days as a consequence of deeper sedation. Secondary outcomes included average doses of sedatives and analgesics and the average sedation burden index. COVID patients did experience a much higher percentage of comatose days, which was in turn significantly associated with a nearly 6 times greater in-hospital mortality. Doses of hypnotic agents were significantly higher in COVID patients, and 52% of the effect of COVID diagnosis on coma was mediated through the indirect effect of hypnotic agent dose. COVID patients received a higher proportion of sedatives and higher doses for a longer period of time, and the sedation burden index was significantly higher for COVID patients during the first 10 days of mechanical ventilation. This may have to do with the fact that COVID patients were also paralyzed more often compared to their non-COVID counterparts, which, as we know, requires deep sedation. There's a lot of interesting data in this analysis that we don't have time to delve into, but I think the biggest take-home point is that the high doses of sedatives we're seeing used in patients with COVID ARDS are associated with prolonged coma and increased mortality. To me, this really highlights the importance of employing our A to F bundle principles and making a conscientious daily effort to wean analgesia and sedation to the best we can while still facilitating optimal ventilation. Pharmacists can play a huge role in pushing this and working with teams to optimize sedation strategies in these patients. I know that's something that the pharmacists I work with and that I personally have worked really hard to work with our providers in doing.
Yeah, there's a really good editorial by pharmacy giant John Devlin, and they reiterate utilizing the ABCDEF bundle and light sedation, and trying to use the least amount possible. And I think this is an indirect. One of the things that's so sad with COVID is none of these patients are able to have very many family members at the bedside, or definitely maybe not continuously around the bedside. And I think sometimes the family members are able to either help calm their family member or loved one down, or can bring light to the fact that, hey, he hasn't responded to me. Letting us know like how deeply sedated they are. I think that's kind of one unseen consequence of it. So I like that. I think we know no matter what is kind of going on, trying to utilize light sedation is going to help everything here.
Yeah.
Now we finished the ventilator blues section, and we're going to kind of take a turn here to the review room where we highlight the best review articles. So Alyssa, stay tight because you have a couple articles here, and the first article is reviewing one of our electrolytes.
Yeah, so I really liked this article because it made me think about how many times I have felt in the ICU like my job was to be the electrolyte police, just making sure everyone's gotten their A and neg, box replaced that day. And this first review article that I have is going to make me feel at least a little more validated on those days when it comes to phosphate repletion. So this article from Dr. Spin and colleagues published in September is a meta-analysis of hypophosphatemia and outcomes in the ICU. Hypophosphatemia is very, very common in the ICU, occurring in up to 80% of patients. And we know that it affects every organ system, causing metabolic encephalopathy, respiratory failure, paresthesias, and hematological dysfunction. However, the bigger clinical outcome of mortality from hypophosphatemia is still controversial, and it's the outcome that this meta-analysis primarily focused on. Their secondary aim was to determine whether hypophosphatemia is associated with increased hospital or ICU length of stay. They included 12 prospective and retrospective studies totaling more than 7,600 patients, and they found no significant increase in overall or in-hospital mortality associated with hypophosphatemia. However, ICU and hospital length of stay were both about 2 days longer for patients with hypophosphatemia, and this was significant. The biggest limitation of this meta-analysis was the observational nature of the studies included. Additionally, the authors acknowledged that there was a lot of heterogeneity in study populations and designs, which may contribute to a less accurate depiction of the true effect of hypophosphatemia on patient outcomes. Ultimately, the authors call for more robust prospective studies and interventional studies of phosphate replacement to be conducted, and I have to agree with that conclusion. though I will feel more validated in harping on providers for phos replacement, knowing that hypophosphatemia likely does contribute to increased length of stay and subsequently hospital costs.
I think one of the hard things with phosphorus, and for the record, I think this is the most underrated electrolyte. I don't think it gets enough love for all that it does, especially for our ventilated patients. Mm-hmm. But I think everyone knows we're going to get BMPs or maybe even CMPs with morning labs. A lot of people remember magnesium, but not a lot of people remember phosphorus. So sometimes it's a process just even getting the lab itself ordered. But I mean, big disease states I think of where this definitely plays a big part is like DKA, things like that, or if you're worried about refeeding or some of those types of scenarios, and then patients who are on CRT where that phos just gets cleared like nobody's business. So yes, definitely a good reason to still be the electrolyte police. I absolutely love that. Okay, Alyssa, why don't you lead us into our next review article?
Yeah, so this next article is a great review, switching gears entirely on neurostimulant use after stroke or TBI. And it was actually written by two pharmacists, Dr. Kakehi and Dr. Tompkins out of Rutgers University, and was published in October in Annals of Pharmacotherapy. The use of neurostimulants post-TBI or stroke is a very gray area in practice because there's not a lot of great data. So the objective of this review was to comb through all of the prospective studies and observational trials published in the last 70 years to describe the efficacy and safety of neurostimulants after neurologic injury and to make recommendations regarding which agents should be considered for use in clinical practice. The drugs they found evidence for can be categorized into CNS stimulants, dopaminergic agents, acetylcholinesterase inhibitors, SSRIs, and GABA agonists. Of these agents, the most supportive evidence existed for amantadine, specifically to enhance cognition after TBI. Methylphenidate also appeared to have some benefits for patients with stroke or TBI. Agents that had some positive effects but a high rate of intolerable adverse events included bromocriptine, donepezil, and dextroamphetamines. There were some drugs which had promising data but just not enough to go all in on them quite yet, and these included levodopa, modafinil, and citalopram. And then finally, they also found some agents to avoid post-stroke and TBI due to lack of supporting evidence, and these included fluoxetine, rivastigmine, ropinirole, and zolpidem. Now, I know I just threw out a lot of drug names and recommendations. Thankfully, all of these can be found in Table 3 of this article, which contains a summary of the author's recommendations. The article also goes into much more depth on the data for each of these agents, which we don't have time to get into. But overall, I really enjoyed this review and especially appreciated the tables they included, which concisely break down which drug classes and agents have been studied in this patient population, along with one-line recommendations based on the evidence that either supports or refutes their uses. So this is definitely worth checking out, and it's a resource I know that I'll be using to quickly turn to when answering questions about these agents for my providers.
Yeah, this seems like a great article to kind of save away on your zip drive. And if you're trying to think of alternatives for somebody, you have different options there. Or if you're maybe just trying to be familiar with some of the literature, I think most of us are familiar with that famous study on amantadine post-TBI and kind of improved cognition, but lots and lots of detailed analysis here. I love when it's a review article on pharmacotherapy written by pharmacists. I think you can kind of tell the differences, especially in the tables and figures and things. So I think that's a really great article that you highlighted from our New Jerseyan colleagues from Rutgers.
Yeah.
Okay, now go ahead and close us out with kind of I would say in the last few years, a fairly new concept in the ICU world.
Yeah, so the last article I have for you today discusses an emerging area in critical care that I am really passionate about. It's about post-intensive care syndrome, also known as PICS. So PICS is diagnosed by the presence of long-term physical, psychiatric, or cognitive dysfunction persisting after patients leave the ICU. And this article by Dr. Martillo and colleagues in September's issue of Critical Care Medicine aimed to describe PICS prevalence after COVID-19 infection. This was a descriptive single-center cohort study conducted in the Critical Care Recovery Clinic at an academic medical center in New York City. They conducted telehealth appointments with 45 patients 1 month after hospital discharge, and their primary outcomes were physical, psychiatric, and cognitive dysfunction as assessed by a variety of tools. Nearly all patients met criteria for PICS with impairment in at least one domain. 87% reported at least one physical impairment, mostly being mobility and pain, and nearly 50% presented with psychiatric impairment, including depression, anxiety, and insomnia. The majority of patients screened for cognitive impairment had no signs of cognitive dysfunction. Ultimately, although this was a very small study, again, only 45 patients, this article does highlight how critically ill patients with COVID-19 still require our attention and follow-up even months after they've left our ICUs. Pharmacists can play a vital part of these PICS clinics by performing medication reconciliations, answering patients' questions about their medications, and even providing recommendations for over-the-counter products to help with lingering sleep issues or pain. This is such a great opportunity for pharmacists to work with their interdisciplinary colleagues to help our patients continue improving after caring for them when they're at their worst. And it can be really meaningful to see people even just up walking around, not in a hospital gown, and provide a lot of closure for us as healthcare professionals too. This was actually something I got to be a part of as a PGY2 with our PICS clinic at Jefferson, and I can say from personal experience, it was one of the more meaningful things I've been a part of in my career. So excited that this is gaining traction and we're starting to get some data on this.
I completely agree with those thoughts. I've had the privilege of going to them, and it's like fulfilling. It fills your cup up. I think we just see so much, like, especially now, there's so much negativity and so much kind of sadness on a day-to-day basis. It's kind of uplifting, right? Sometimes we need some positivity and optimism. And I think these clinics where you're able to take the time to help people who made it through their ICU stay I completely agree. It's one of the most rewarding things. And if this is a new concept or you're hoping to learn more, one of our first episodes, I was lucky enough to be joined by Jimmy Haddon-Kolpick, who from the University of Kentucky talked about PICS clinics, setting them up and things like that. So it's a really good episode if you all haven't heard that. So really good review articles. I wanted to highlight two kind of honestly fantastic 50th anniversary review articles from critical care medicine. The first is titled Hemodynamic Monitoring Support, and it really kind of discusses different hemodynamic concepts, their importance. It has visual aids to help explain all that goes into certain values, like calculating your SCVO2 or cardiac output, and even goes into the equipment used to monitor. I think it's one of those that it's a great article to save and bring up, kind of help with hemodynamic and vasoactive topic discussions. And the second article builds off Alyssa's last review article and is entitled Patient and Family Engagement in Critical Illness. And it gives a really great history into patient, family, and centered care, a discussion of the benefits of using that now, as well as other initiatives like PICS clinics and all that does. So I think that's a really, really good way to kind of end the review room, kind of talking about these new initiatives that are so great for our critically ill patients. All right, Sara, I hope you're still with us here. I told you to hang around just a second here because now we're ending with the front of the fridge, showcasing some of our pharmacist-driven studies. And I think Sara identified some really good ones. So why don't you take the floor here for the first one?
Yeah, so again, keeping consistent with the infectious disease theme, a great pharmacist-authored article. And again, some of the pharmacists in some of these articles that I'm going to review, are people that I view as, mentors or people that I look up to, within the ID world. They've done profound work. So one of the first articles I wanted to review, was published by Emily Hylett and colleagues in OFID, or Open Forum Infectious Disease. And they reviewed, the treatment of uncomplicated gram-negative rod bloodstream infections utilizing a modified Delphi approach. So currently there are no formal peer-reviewed guidelines for the management of uncomplicated gram-negative bloodstream infections, and formal guidance on aspects such as duration of therapy, use of oral antibiotics, as well as the need for repeat blood cultures are lacking. So again, this publication aims to provide some semblance of an expert consensus in this area where official peer-reviewed guidelines do not exist. The panel of ID experts that consisted of 6 pharmacists and 7 physicians who were blinded to each other participated in a consensus process to describe their preferred management approaches of uncomplicated gram-negative bacteremia or bloodstream infection. These panel members answered an array of questions related to, if they agreed or disagreed with the statement regarding the management of this type of infection. So amongst the panel, the definition of uncomplicated gram-negative bacteremia was agreed upon as a bloodstream infection in a non-immunocompromised patient, secondary to either a urinary, intra-abdominal, catheter-associated, uncomplicated pneumonia, or a skin cell tissue source. Source control is achieved, and there's evidence of clinical improvement within 72 hours of antimicrobial therapy. Overall, the group came to the conclusion on the following parameters. Appropriate duration of antibiotic therapy for uncomplicated gram-negative bacteremia is roughly 7 days. Repeat blood cultures are not necessary unless there's a concern for a lack of source control. And oral antibiotics can be used when the following is, met. The patient improves clinically on intravenous antibiotics and has a working GI tract. Source of infection is confirmed, and our oral options, albeit with adequate pharmacokinetic and pharmacodynamic target attainment, are viable based on susceptibility data. Notably, the authors did mention that they prefer fluoroquinolones and sulfamethoxazole trimethoprim, given their high bioavailability, with oral beta-lactams as an alternative. Although this isn't an expert opinion consensus document, I think this has applicability, as I believe the lack of formal guidelines was essentially the reason for this publication, so as to provide some type of guidance to clinicians who are treating patients with gram-negative bloodstream infections, which again, as we know, is a commonly encountered clinical scenario.
Yeah, I think this is an awesome document. Even though, like you said, it's not guidelines, we have, kind of expert consensus. I think when you dive into guidelines themselves, you find more and more that a lot of them are based on this expert consensus. And to be honest, with these gram-negative infections getting nastier and nastier, I think we will take all the help we can get from our ID colleagues. And you're absolutely right. I mean, Emily Heil, even if I'm not an ID pharmacist, she's from University of Maryland. I think you're just going to be familiar with her name if you're familiar with any type of ID or antimicrobial stewardship or literature itself. So a really good point. Now, kind of building on that, thinking of keeping on our antibiotic theme here, let's talk about a little dosing here, Sara.
Yeah, so I wanted to focus on an article that I thought was really good, focusing on a core concept that I think pharmacists should be cognizant of. So again, as we know, our beta-lactam antibiotics are often the backbone of antibiotic therapy in the critically ill, as mentioned through some of the previous studies that I reviewed throughout this podcast. So this was a review article published by Kelly McGuigan and colleagues, published in the journal Antibiotics. And this review article examined literature related to the pharmacokinetics and pharmacodynamics of beta-lactam antibiotics, as well as their associated pharmacokinetic models in ICU patients, in order to determine desired dosing regimens for critically ill patients with infections with, quote-unquote, less susceptible gram-negative organisms. Now, this definition of less susceptible was based off of UCAS, or the European Committee on Antimicrobial Susceptibility Testing, breakpoints, which is something I will get to later in my discussion. Overall, the authors found that continuous infusions of beta-lactam antibiotics achieved the desired PK/PD targets, which makes sense considering that our beta-lactams exhibit bactericidal activity via time over MIC. The authors recommended continuous infusions for agents such as piperacillin, tazobactam, and cefepime. For other agents such as meropenem and imipenem, the authors recommended regimens infused over a 4-hour duration. There is a lack of stability data with ertapenem to recommend continuous infusion, and a lack of data overall with ace-treonam to say that continuous infusion would be more efficacious than the typical dosing. So again, this article reviewed important PK/PD concepts that pharmacists should understand. The caveat with this article is that when examining their PK models, the authors included studies that utilized the UCAS breakpoints to determine organism susceptibility, and not that of CLSI, or the Clinical and Lab Standards Institute, which is what we utilize here in the U.S. It's important to note that there are some differences between the two agencies and their recommendations for antibiotic breakpoints. It also is unclear what patient outcomes may be with the author's suggested dosing strategies of continuous infusion. Lastly, critically ill patients in the ICU have rapidly changing parameters such as renal function and volume of distribution that may make continuous infusion tricky to pursue in terms of mitigating toxicity. Therapeutic drug monitoring is recommended by the authors, but this practice has not been fully adopted into practice with beta-lactam therapies. For example, at my institution, we currently do not do therapeutic drug monitoring with beta-lactams, although I know that there are other institutions that have adopted this practice.
Yeah, we're always looking for more PK/PD studies, and this just kind of adds more to it. I think if in doubt, your patient's getting worse, what's growing. I think we know there's more and more data coming out that, continuous infusion is probably even better than our extended interval infusions, which we know both of those are much better than our standard infusion. So kind of low and slow, right? Like instead of we're thinking the tortoise and the hare, this is going to be the tortoise here. And then, kind of the University of Florida colleagues, they're doing a great article. And then kind of finish us out here, Sara, for the front of the fridge, talking about all these awesome pharmacist-driven studies.
Yeah, so the last study I wanted to review revolves around the treatment of carbapenem-resistant Acinetobacter baumannii infections. This was an article that was published in Pharmacotherapy. As we know, in the CDC's 2019 Antimicrobial Resistance Threats Report, carbapenem-resistant Acinetobacter baumannii, or what I'll lovingly refer to as CRAB for the remainder of this discussion, is designated as an urgent threat, which is in fact the most serious threat designation. Infections with this organism are incredibly challenging to treat, as optimal treatment is ill-defined, and therapy often involves antibiotics with toxic side effects. So again, this was a review article published in Pharmacotherapy, and they reviewed and evaluated the microbiologic, PK/PD, as well as real-world clinical data on the treatment of CRAB infections. What the authors noted is that the optimal agent or optimal combination of agents for severe CRAB infections remains to be identified, unfortunately. However, options that we might have at our disposal include agents such as tigecycline, minocycline, the less desirable polymyxins and colistin. We have high-dose ampicillin sulbactam, as well as some of the newer agents such as eravacycline and cefiderocol. Results of observational clinical studies have varied and have often been inconclusive, with noted limitations such as small patient sample sizes. And unfortunately, there is limited real-world clinical data. It also may be challenging of note to achieve those PK/PD targets, again, going back to the last article I reviewed and how important that is, with the agents that are susceptible at current FDA-approved doses. And unfortunately, safety data of higher dosing of our antibiotics, again, such as with high-dose ampicillin sulbactam, is limited. Mortality is noted to be high in patients with severe CRAB infections, and in most of the studies included in this review, it was noted to be at least 40%. As a result, it's evident that newer antibiotics with efficacy against CRAB and those antibiotics with reduced side effect profiles are desperately needed. This review article provides helpful insight into the challenges of treating CRAB infections that both providers and pharmacists should be aware of when selecting therapy. Even with the recently published IDSA guidance on multi-drug resistant infection, published by our colleagues Pranita Tama and Sam Aiken, which included reviewing the treatment of CRAB, there is still clearly no clear-cut consensus on how to manage patients who have severe infections with CRAB.
I save all of these review articles, but to make you feel better as job security, this is one of those bugs that I'll always message ID colleagues or always make sure that we have ID consulted, because it feels like the data and the literature changes every week with some of these nasty organisms, but it's always nice to have great review articles for us non-ID folks, hoping to keep up with everything. So yeah, it was a really, really good article, and something that I think is one of those zip drive worthy ones that maybe you don't read right away, but you kind of pull it up based on a patient that might be a little tricky.
Yeah, I think it's definitely a helpful document. And, from my own, anecdotal experience in seeing patients with carbapenem-resistant Acinetobacter or Acinetobacter infections in general, it's either, pretty friendly or pan susceptible, or it's really nasty and it's very resistant. And that is when, we have to put our thinking caps on and, help our colleagues, pick the most appropriate combination of drugs and make sure that they're dosed appropriately.
Wise words. You're absolutely right. Well, Alyssa and Sara, I thought this was just an absolute great job summarizing our articles that were published in September and October, but we can't end just yet because everyone knows if someone from Philly, anyone has any ties to Philly comes on the pod, we need cheesesteak recommendations. So, Alyssa, we gave you all a little bit of time to think here. So, Alyssa, why don't you start with, like, if someone's visiting and they're asking you for a cheesesteak recommendation, what's your go-to? And then Sara will follow up with your thoughts.
Yeah, so Sara is a Philly native, so she probably has much more sound recommendations on this than I do. But because I lived in Philly during the pandemic, I didn't get to go to many places in person, but I did do my best to try as many cheesesteaks as I could order to be delivered to my door. One that I ordered the most often was from Cleaver's, which if you're looking to go in person, it's on 18th and Chestnut near Rittenhouse Square. But all of their cheesesteaks, they have so many, and they're all, my mouth is watering thinking about it. They're so good. Several have also been endorsed by my dog because he would jump up and get a hold of half my cheesesteak on more than one occasion. They've got all sorts of loaded fries and milkshakes as well. But yeah, just so many good options at Cleaver's. I'm here for it.
Now, Alyssa, you said you ordered a lot of these delivery. Cheesesteaks feel like one of those that probably holds pretty well for a delivery ride. There are some things that are shaky, but how does that hold up?
Yeah, I never had an issue with cheesesteaks that I got delivered to me. They were always fantastic. So really anywhere that I went in Philly, it can't go wrong.
All right. Now, Sara, the Philly native, now to bring people in, I told her there's no wrong answers unless she says one of the big three, Pat's, Geno's, or Jim's. That would be a wrong answer here. So, Sara, what's your go-to as the native?
I would never commit a sin like that. But first, say, so I also love Cleaver's. It's not my choice, but I'll mention it because I think it's ironic because I actually just moved and I am like a block away from them and everything on their menu is fabulous.
That sounds like a gift and a curse being a block away from a place like that.
Sadly, unfortunately. But all right, so I'll give you my prime recommendation and I'll give you the low-key Philly local recommendation. So my more well-known recommendation, it actually doesn't even have cheesesteak or steak in the name. It's called John's Roast Pork. It's in South Philly. Literally the best cheesesteaks you'll ever have. You heard it here first. Maybe you haven't. I don't know. But my more local, low-key option, though, would be Angelo's Pizzeria on 9th Street. Again, amazing cheesesteak. So you can't go wrong with either places.
That's a curveball. That's hiding in plain sight. A pizza place is like a low-key favorite cheesesteak spot. Uh-oh.
They both have Instagrams. They both have Instagrams. Like, you just got to go on and see a picture, and you're like, I know what she's talking about.
I like that. But I've had so many Philly people on indirect, that are indirectly related to it. I feel like when I finally go, I'm going to have like 8 places that I need to try with a lot of South Philly places. It's not the first South Philly spot we've had recommended on here.
I know. And unfortunately, fortunately or unfortunately, one year when I was in high school, couple of my friends and I decided to go on a cheesesteak tour during the summer. And I think we literally went to a different place every week of the summer. So my recommendations are sound. I think I've taste tested just about almost every place you can think of.
I love that. If we're looking for ways for passive income for you on as a side gig, maybe we have cheesesteak tours as something to keep in your back pocket here.
I would pay to come to a Sara cheesesteak tour. Just say.
Well, I can't think of anything better to end on than amazing cheesesteak recommendations. Sara and Alyssa, thank you so much for coming on the pod, for your awesome insight and reviews into these studies, and as well as kind of diving into the sepsis guidelines. There's going to be tons of people that learned a whole lot from this. Now, as a reminder to everybody, if you want to reach out, reiterate how great of a job they did, Sara's Twitter handle is at SG_PharmD19. And then Alyssa's Twitter handle is at ASyked, so ASYKED PharmD. So that'll be on kind of the promo posts and things like that. So Sara and Alyssa, thanks so much.
Thank you. Thank you. This was so much fun. Yes.
Well, the feeling is mutual here, so I really appreciate it. And of course, for all the listeners of the pod, if friends of the pod, if you want to get in touch, remember Twitter at PharmacyToDose, TO2Dose, or via email, PharmacyToDose@gmail.com. Reminder, if you want to be a guest host, if you want to do what Alyssa and Sara did, the 2022 literature review series kind of survey for guests is going to be open. So fill that out. Send me some emails. If you have any questions, comments, concerns, reach out to me. But until next time, I'm Nick Peters, and this is Pharmacy to Dose, the Critical Care Podcast.